Society of Medical University of Silesia in Katowice, I'd like to thank you all for coming and taking part in International Medical Congress of Silesia 2025. My name is Małgorzata Toroń, and I have an honor of moderating and coordinate the session of Gynecology and Obstetrics. I'd like to cordially welcome our esteemed jury, Professor Mariola Czajkowska, przepraszam bardzo. Profesor Andrzej Witek, MD, PhD Patrycja Figler-Rudol, dr Tomasz Wikarek i lekarz Robert Peterk. We would like to explain to you the rules of the session. I pani profesor...
Przepraszam, czy ja w takim razie mam również w tej sesji brać udział, czy nie?
Tak, i pani profesor Anita Olejek, która jest z nami online.
Dzień dobry, dziękuję bardzo.
We would like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book. Maximal time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I'd like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation, and the assessment will be verified. I'd like to remind you that if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are obliged to answer in English. We kindly ask the jury to assess scientific value from 1 to 5, way of presenting from 1 to 5, discussion from 1 to 5, and own contribution from 1 to 5. That's why at the end of the presentation, we will ask the question, what was your contribution to this work? When the session ends, we kindly ask you to give the cards back to the coordinator. And to begin, I think we can start with our first presentation, which is the knowledge about HPV vaccination among individuals aged 18-58. The floor is yours. Thank you.
Estimated jury, dear colleagues, ladies and gentlemen, today I would like to present our study. It's knowledge about HPV vaccination among individuals aged 18 to 58. The HPV virus is not just a common infection, it's a global health challenge with over 200 identified types of the virus. It ranges from the harmless to the highly oncogenic ones, and the low-risk types cause some benign growths such as genital warts. And the real concern lies in the high-risk ones, which are directly linked to a cervical cancer, as well as malignancies of oropharynx and other anogenital areas. The distinction between low and high-risk types plays a crucial role in understanding the pathogenesis of the HPV-related diseases and helps guiding preventive strategies such as vaccination. And the aim of our study is to assess public knowledge and understanding of HPV vaccination. We surveyed 352 people aged 18 to 58 about their awareness of the HPV and their opinions about the vaccination against it via social media. Especially we use Instagram, and the following data were evaluated, especially, as I said, the knowledge about HPV and the knowledge about vaccine against it. We are still collecting the data, but for now our study group consists of over than 300 participants, the majority of whom were women, and the average age of the participants is about 29, and a lot portion of the participants had from 1 to 2 sexual partners. The majority of our male and female respondents are aware of the HPV existence, although there still remains some percent of the individuals who are unfamiliar with it. Impressively, the majority of our respondents correctly linked HPV to a cervical cancer, but only about 23% of the respondents can correctly identify 3 health conditions associated with the HPV. We listed that conditions in our survey. About 25% of our male respondents had never heard about the vaccination against HPV, and about 86% of them are unvaccinated. The situation among women is slightly better. However, the percentage of those unvaccinated remains still high. The internet dominates as a source of HPV vaccination information, although about 30% of our respondents is relying on it over the medical professionals. And shockingly, about 30% of our respondents had never been informed about the possibility of vaccination during their gynecological visit. Most of our respondents were aware that boys and girls can be vaccinated, and there is a possibility of a vaccine after the initiation of sexual activity. The most divided opinion concerned about the possibility of vaccination after confirming the HPV infection, and about 37% of our participants thinks that it's not possible to vaccine after confirming the infection. Most of our respondents believe that HPV vaccine should be mandatory. Only about 18% of them would choose not to get vaccinated, even if it will be fully refunded. The minority of our respondents rated their knowledge about HPV as a poor or very poor. And in our age, in the first of our age group, the percentage of those vaccinated is higher than in the second one. And to conclude everything, the HPV awareness exists, and increasing the education, the access to the vaccines, and boosting the funding can make the vaccines rates even higher. And the strong social belief in the importance of the vaccination provides optimism for the future for reducing HPV-related cancers. And thank you for your attention. I will be happy to answer your questions.
Thank you very much for your presentation. Are there any questions from the jury? So let me ask you, what was your contribution?
So first of all, we did the research for our work, and then I participate in the creating of our survey, and then I tried to reach some medical influencers to ask for help with the distribution of our survey. And then I created this presentation, and here I am, and I'm presenting it.
question. First question is very simple. I would like to ask you about who was author of this questions. This questionnaire was done by your group, or
They were done by my group, but we were firstly checking the guidelines of the Polish so
questionnaire? Okay.
questionnaire.
Okay. And may I ask you about your conclusion? Because for me it is very important. I found that a strong social belief in the importance of vaccination exists here in our population, but vaccination rate is still unsuccessfully and very low. What is the reason? We know about vaccination, our information about vaccination is correct, maybe correct, but the vaccination rate is for in group of children, teenage, is not as should be.
I think that the anti-vaccination groups are there are a lot of myths about the vaccine against HPV, and I think that some kind of social campaigns that will say the real information about it and will help people understand the importance of that. And also, I think that it should be a topic which will be more that people should talk more about it, because I think that communication is the key. Also in medical professionals and in the schools and anywhere else.
Yesterday, I found information about the rate of vaccination here in Poland according to year of born, and it is still under 20%. It's very low, and we shouldn't expect a success, for instance, like in Nordic countries or Australia, in New Zealand, but it is very difficult to change it here in Polish population. Thank you very much.
Thank you.
Thank you very much for your presentation. And now let's move on to our next presenter, Radosław Karaś. Okay, so I'm sorry. Agata Gondek with the work Aberrant Right Subclavian Artery, an important additional marker in prenatal fetal examination.
Okay, good afternoon, everyone. Thank you for coming. My name is Agata Gondek, and I have the pleasure to present the topic Aberrant Right Subclavian Artery, ARSA, an important additional marker in prenatal fetal examination. Okay, so normally, 3 vessels arise from the aortic arch. It is brachiocephalic trunk first, and then it divides into the right subclavian artery and the right common carotid artery. The second vessel is left common carotid artery, and the third one is left subclavian artery. But in about 1% of cases, the right subclavian artery does not originate from the brachiocephalic trunk, but instead it arises as the 4th vessel from the aortic arch, as you can see. Then it moves, it passes behind the esophagus, sometimes also between esophagus and the trachea, or the rarest in front of the trachea. ARSA is the aberrant right subclavian artery, as I said. It is often detected during prenatal fetal screening. And it was firstly described by François Renaud, French anatomist, in 1735. Here you see some pictures from ultrasound examination, and this shows the typical one, right subclavian artery, and comparing to aberrant one. Okay, the aim of this study was to conduct a detailed analysis of fetuses with ARSA detected during prenatal fetal screening, focusing on its association with congenital anomalies and chromosomal aberrations. It was a retrospective analysis of 16 fetuses with ARSA and methods, imaging equipment, statistical tests, as you can see. The average age of studied patients was 32.8 varied to 5.65 years. But let's move to the results finally. So isolated ARSA was observed in 10 out of 16 cases. Isolated means without any other structural abnormalities related to soft markers. So it was about 62%. Normal karyotype was found in 13 cases, but remaining 3 cases included one case of trisomy 21, one case of tetrasomy 9p, and one case of chromosome 18 deletion. But the most common, abnormality was cardiac defect. It was tricuspid regurgitation, also some septal defects like VSD, ASD. We also found out 2 cases with 2 vessels umbilical cord. It was connected to those syndromes like chromosome 18 deletion and tetrasomy 9p. We found out also that mother's age does not correlate to isolated or non-isolated ARSA occurrence. But in general, I would say that ARSA is one of the, maybe not the most common, but it is common marker anomaly, for in aorta. It is responsible for up to 3% of anomaly connected to aorta. As I previously said, it is a significant marker for trisomy 21, even when isolated, what also has been reported in the literature. Moreover, ARSA may co-occur with some genetical defects, what has been proved here in this study. And it was, for example, here it was tetrasomy 9p, chromosome 18 deletion, and tetrasomy and trisomy of 21. But also it could be trisomy 13, 18, Turner syndrome, or microdeletion 22.11, which is the George syndrome. But the most common coexisting problems were cardiac defects. It was connected to septum, septal defects, also some valves dysfunctions, or even right-sided heart anomaly. If it goes about other abnormalities, it was nasal bone hypoplasia, clubfoot, or even fifth middle phalanx absence. ARSA is usually asymptomatic, but sometimes can present dysphagia, which is connected to weight gain problems later. Also dyspnea and respiratory failure with stridor and coughing. It is because ARSA is in close proximity to the esophagus and the trachea, as I said before. Okay, to sum up, ARSA may be an important marker in prenatal fetal screening. It is important to find it because we can sometimes predict some symptoms. We can treat some symptoms. Also, we can plan a neonatal care or possible treatment if needed, depending on symptoms. And families, finally, can receive expert advice, and it is also connected to genetic testing. Okay, thank you for your attention. If you have any questions, do not hesitate to ask.
Thank you very much for your presentation. Are there any questions?
I would like to ask if it's possibility.
Yes, of course.
So how many cases of negative significance of these markers do you found in your examination or in literature?
Okay, so
It is also connected with some abnormalities in fetus, or there are cases when this anomaly was observed, but the child was born completely healthy.
Yes, sometimes it can be just a single anomaly, and it's not connected to any symptoms. So it doesn't mean that the fetus needs to have some abnormality in karyotype, for example. We had 16 fetuses with ARSA detected during prenatal life, the prenatal fetal screening, and only 3 of them had abnormal karyotype. So it's not as much, but it is usually connected with some cardiac defects, as I said before. So
how heavy cardiac defect? Because do you think that it can be the reason to terminate the pregnancy?
I don't think
or
so.
The child could be operated after delivery.
Okay, so I'll start from the last question. Actually, ARSA does not need to be treated, so it can prevent some symptoms that can occur later in life. So it's just good to know. I think it's important marker. We can sometimes predict some defect. Like, for example, I would say about one case, one publication. There were in 6%, we found that they found actually trisomy 21 after finding ARSA. So ARSA was the first marker of trisomy 21, and they detected this syndrome later. So it's quite interesting, I think. Thank you for this question.
Now, there is something what will be developed in the future, much more, I think, yeah?
I think so, yeah.
Thank you.
I've got the technical question, but if we observe isolated ARSA during the ultrasound examination, should we do something and should we inform the patient about this situation?
We can inform the patient, obviously, but it doesn't need to be treated, or operated or something. So the patient doesn't need to undergo any special surgery.
So
it can be related to some disease or defect, but doesn't need to. It can be just a single isolated, without any other structural abnormalities, marker.
okay, thank you.
You think that this examination should be including in prenatal fetal screening?
I think
just
yes.
now?
I think yes.
According your knowledge about literature or your experience, and where did you do it? In anatomic theater?
Okay, so firstly, I think yes, it should be included. The more information, the better. It may help indicate some syndromes, some defects. So it's always better to know. So it's good to have experience in that and use this marker in the routine examination. But second question, so it started in anatomy club, as you said, obviously. And then we decided to just prepare the publication, yeah, about real
But you
and
have
live
medical
patients.
documentation because it was a retrospective
Yes.
examination from medical documents. And medical documents you found not in anatomical department or theater, only in the hospital, in obstetrics world. Yes?
Sure. It was found in anatomy lab, firstly, sporadically, but still.
Okay, thank you.
And thank you.
Thank you very much for your presentation. And now let's move on to the next presentation, which is Wiktoria Lizińska with
Members of jury, ladies and gentlemen. As you probably know, the Poland population is still declining, not because only the aging population and the modern life choices, but also with increasing rates of Poles who suffer from infertility. On the other hand, the government launched the in vitro fertilization program, which is actually pretty good because Poland have shifted last year from 42nd to 19th place in Europe when it comes to infertility treatment. Taking things together, we wanted to assess the level of Polish people about the knowledge of in vitro fertilization and check their awareness about this program. And what's more, we wanted to also examine the attitudes and emotions as well as ethical aspects about Poles towards IVF. In order to achieve it, we conducted an online structured questionnaire, which was prepared and conducted online. We included people over 18 years old who had internet access. We got bioethics committee approval and we performed statistic analysis. Our questionnaire was divided by many subsections. The first was by the gender, the female. After that, the female were divided into a woman who had not given birth and who had, and the men who have children and who do not. And after that, the people were divided who did not have a child, whether they don't have child because they don't want to, simply, and the people who just have medical complication and they are not able to conceive. Apart from that, everybody was obliged to go through sections like socio-demographic characteristic, about the factual knowledge about IVF, about other also ethical consideration of the IVF procedures. So our statistical responder was a female, around 34 years old, mainly from big city. Big city, I mean more than 100,000 people, with average socioeconomic status, and most responders had higher education. And the people spent around 11 months trying to conceive. And I want to emphasize that people describe their knowledge very average, and they get information from internet newspaper, which was followed by books and campaigns, which is actually good to know to invest in such as activities. And gynecologists and doctors were at the bottom. So when it comes to the factual knowledge about the IVF, so I look, there's probably not the presentation I've sent it, but I will come through it. So actually the woman who had gave birth and who get through a medical complication with trying to conceive and their partners had the best knowledge about the IVF. And the least knowledge about IVF had people who didn't want to have child just because of their choice. And when you look at the question about the IVF, the main when we look at the question, the very basic things such as what the main application, what the terms mean, the procedures, the answers were pretty good. But when we look about the side effects and contradictions to IVF, the results were lower, actually up to 40% of correct responders. When we look at the governmental funding part, we also saw that the statistic looks very comparable to the knowledge about the IVF, but the question where the percent of correct answer were actually lower. And when we look at the, for example, if IVF is available to same-sex couples and it is founded by NIZ, and the question where the scores were better, but when we look, for example, about is it marriage required to participate in program or what is minimum duration of infertility that we have to treat, the response were actually smaller. And that's that. And when we looked about the IFV controversial, actually, whereas most people think that this is a controversial topic, actually their attitude is towards more liberal to it. And for example, most people do not think that children for IVF are in any kind different, and the disposal of unused embryos is a violation to the right to life. And people actually support the public funding for IVF, and they think that it should be available to every couple who suffer from infertility. And our limitation is that the participants were mainly residents of Łódź and surrounded cities, and sometimes we saw the reluctance to participate in the study because of the sensitivity of the topic. And what's more, the participants have secondary or higher education mostly, so that's our limitation. And our conclusion is while the basic medical question regarding IVF are not the challenge for the responders, the knowledge about funding program is still unsatisfactory. And about the ethics, the IVF is controversial, but actually the response seems to be more liberal in this case. And Polish gain the knowledge mostly from the media, and doctors play the smaller role, but actually school plays none actually. So that's our references, and thank you so much for attention.
Thank you very much for your presentation. Are there any questions from the jury?
I have two questions. Thank you very much for your presentation. It was really interesting. As we all know, the emotions are always speaking louder than information, are always the loudest to the society. So in your opinion, what was the most shocking result? And if you may, tell us more about these questions which are controversial. And the second question is, how was this questionnaire distributed? Because as I heard, it was via online methods, but what exactly were the methods? Thank you.
So actually, I will say the second question first. So we had an online survey that was distributed through Facebook groups dedicated to women and to men and couples with infertility problems. And also we have printed this QR code, and we put it in the department and ask the patient to scan and to reply for the questions. And we also have printed the QR code and we tried to walk through the city center and ask pedestrians to feel, but that's where we found the reluctance to participate in the study. And about the first questions, the emotions actually, I would say the people, it's sensitive topic, and the people, even though they have, I don't know, mainly negative emotions, they seem to be very, preserved and sit back and not to, how to say, not to rush into other people's lives. So that was actually pretty good. So,
Thank you.
Yeah, it is. If I could say something, I think that is very interesting work. You show there that in big cities, in the big population, in a big city, the people think quite different than in small towns or villages, especially in eastern Poland. I remember when the first in vitro fertilization was done in our clinic in Bytom. It was in 1990s. The patients, especially from eastern Poland, they even didn't want to us to write in their papers that the child came from in vitro fertilization. So I think that our society changed a lot, and I think that for very big number of couples, this governmental program is a blessing because it allowed them to have children. So it is very interesting work. Thank you.
okay, thank you so much.
And what was your contribution? The last question.
My contribution was to search through literature to find what question should we ask about the IVF procedures. Then we divided. We were 4 persons. Everybody was responsible for one part of the questionnaire, and I was walking through the hospital and through the streets. And after that, I was doing the presentation. So yeah, that's my contribution.
Thank you very much for amazing presentation. And now let's move on to the next presentation, which is genital tract infections, genetics and breast milk. Do they have anything in common? By Kamil Górecki. The floor is yours.
Thank you so much. Okay, so the genital tract infections during pregnancy are among the most common complications of the pregnancy. And they require prompt diagnostic procedures and treatment in case to protect the mother and the children. Yes. So, however, we know that the infections can alter the milk composition, especially when we talk about the antibodies passed on to the mother, from mother to the children. So today I would like to talk with you about something different, which is if the infections, diseases during pregnancy can affect the milk composition and the microRNA expression in the milk from the breast. So my name is Kamil Górecki, and I hope I can encourage to reflect on this topic with me. But before we start, I will briefly remind what microRNA is. It is a small RNA molecule, about 20 to 22 nucleotides long. So their main function is to inhibit mRNA translation. Thus, it's regulate the gene expression. So they are a key factor in producing proteins, aren't they? So urogenital tract infections can cause severe complications such as preeclampsia, preterm delivery, or low birth weight. So, as I mentioned before, we already know that the infection can affect the milk composition from the breast. So the aim of this presentation was to investigate whether the infection during pregnancy can affect the microRNA expression in the breast from the milk. Okay. So this study was funded by the Medical University of Lublin, Poland. So this is the case control study, including 31 women at the term admitted for delivery. So the 8 patients had the genital tract infections during pregnancy, and 23 did not. 14 women delivered vaginally, and 17 underwent cesarean section. So right now we can see the description of the study group. And what is worth noting is the difference between the control and the study group in terms of age and also in the newborn weight. So let's move on to results. Okay, so as we can see, the microRNA expression in all 4 selected microRNA was significantly lower. And also, all these results were statistically significant. So, to our knowledge, this is the first study to assess the microRNA expression in milk and breast milk cells and their correlation with infection during pregnancy. Also, our study supports earlier studies that showed the maternal factors such as BMI, smoking habit, or age can influence the milk composition. Moreover, the microRNA regulate the immune and metabolic processes. So the changes in their expression of this microRNA may influence the infant development. So to sum up this work, as we can see, all 4 selected microRNA in the group of patients with infection during pregnancy were significantly lower. So maybe, oh, it doesn't work. Oh, it's working. Fantastic. This microRNA may serve as potential biomarker, but we need further studies to assess that. Also, unfortunately, there was no link found between the microRNA or gestational age or form of delivery. But before I end my presentation, what is ahead of us? Okay, so our next study will further explore the potential role of this microRNA, which could serve as potential biomarker, especially for asymptomatic patients. That's my bibliography, and thank you for your attention.
Thank you very much for your presentation. Are there any questions from the jury? Excuse me, can you take a mic?
Thank you very much. It was a very interesting study. Congratulations. And my first question, I've got 2 questions. First question connecting with modalities of delivery. First group delivery best natural via vaginal, and the second is cesarean section.
Yes, so
it was differences between 2 groups in your markers.
Okay, so between the form of delivery, there was no statistically significant differences. So, but when we talk about, for example, the group of patients who had the genital tract infection, 6 of those patients underwent a cesarean section.
I mean only on group with infection.
Okay.
Because quite different will be when the delivery 12 hours through vaginal, which is infection, where there is infection, or cesarean section is the result, in my opinion, should be quite different.
Yes,
did you find it?
We also suppose that there will be differences, but the statistical analysis showed there wasn't any significance like the difference. It was weird, but
okay. My second questions Have you any other factors that may influence on the decrease? Because not only infection in tract, vaginal, etc., but also another infection would be influence on your results.
Okay, so in this study, we only analyzed the vagina infections, but I know that this study has limitations. So like the main goal was to check if there is any differences, but further studies are necessary to analyze because we also didn't analyze if there is a bacterial infection or virus infection or candida infection. We didn't like check the differences in the scores or in the results. So I know this is a limitation of this work. So I think I cannot answer to this question like right now, but maybe in the future.
Okay, but in my opinion, your second or third conclusion is very interesting when you said that microRNA is maybe an indicator of infection.
Yeah, I hope it will be, especially for asymptomatic patients, because it could be a really big problem, especially if the, for example, infection is detected not in the like first stage or really late. It can cause a. Yeah. Thank you. I'm also really thankful for this discussion. Thank you.
The last question, what was your contribution?
So my contribution was to collect the data and writing the manuscript.
Thank you very much for your presentation. And now let's move on to our next presenter for today, who is Aleksandra Golec, with the work Knowledge about HPV and its prevention among women of different age groups.
Okay, dear attendees, it is my honor to present to you today the findings of our latest medical research on knowledge about the HPV and its prevention among women of different age groups. Through tireless efforts, we have gathered some valuable data on the level of awareness, knowledge of prevention methods, and long-term health consequences. And without further ado, let's begin our presentation. Human papillomavirus is a common viral infection that affects both men and women, but it is particularly concerning women due to its association with cervical cancer and other reproductive health issues. Despite its prevalence, awareness and knowledge about HPV and its prevention methods, such as vaccination and regular screenings, vary significantly among different age groups. Our aim was to assess knowledge about HPV among women of various ages and level of education. To obtain crucial information, we created an anonymous survey containing questions about HPV. A total of 60 women over age 18 participated. The majority of our population were women aged 18 to 34 with higher or secondary education. 3/4 of respondents had 0 to 3 sexual partners, and almost all of our population identified as heterosexuals. When it comes to HPV prevention methods, a little over half of our respondents reported condom use during intercourse. Moreover, almost 70% undergo both conventional pap smears and liquid-based cytology. In our survey, 100% respondents reported being aware of HPV and the HPV vaccine. A significant majority recognized that HPV can be asymptomatic, highlighting the understanding of the virus's nature. Furthermore, over 80% identified cytological tests as effective tools for identifying cellular changes caused by HPV. When comparing diagnostic methods, almost 70% considered liquid-based cytology to be more accurate than conventional smear tests. Despite this level of awareness, great majority still felt that public understanding of HPV remains insufficient, emphasizing the need for continued education and outreach. Most of the respondents gained knowledge from internet, doctors, as well as school. The majority of respondents know that HPV can lead to cervical cancer, and about 60% are aware that HPV causes changes in the cervix. Around 40% believe that HPV can be cured and that it is only transmitted through sexual contact. While fewer respondents know that most HPV infection resolve on their own. Only a very small percentage admitted they do not know anything about HPV. The majority of respondents recognize that HPV can cause cervical cancer.
Decyzji nie podejmować pacjentów też nie skieruje, dlatego że on pracuje w tej prowicie, tam gdzie przecież w ręku tam poszedł przyjmować ciężarne. I ja się, no po to poszedł. Ja nawet nie wiedziałam, że tam ta Magda jego też pracuje.
Czy mogłaby się pani profesor wyciszyć?
Around 50% are aware that HPV can lead to skin warts, while fewer participants know about its link to anal and throat cancer. Only a small percentage admitted they do not know the health consequences about HPV. Among the respondents, 1/3 reported being vaccinated against HPV. A majority believe that the vaccine is effective. Additionally, almost 90% are aware that the HPV vaccine does not treat an existing infection, and the same percentage also correctly identified the best age for vaccination as between 9 and 14 years old. Doctors still remain the most trusted source of information about HPV. It is very promising that the awareness of the HPV virus is generally high. However, preventive behaviors remain insufficient. Not even half of surveyed women are vaccinated, undergo regular pap smears, or have completed HPV DNA testing. These findings indicate a clear need to promote vaccination and regular screening, as well as to raise public awareness about the possibility of asymptomatic HPV infection. We as doctors and future doctors need to step aside and raise awareness of this very common health problem. I hope that findings we obtain will somehow contribute to medical advancement in the future. Thank you very much for your attention. And if you have any questions, you are more than welcome to ask them.
Thank you very much for your presentation. Are there any questions from the jury? So maybe.
Presentation here in this session, it was the same questions. Our knowledge, our population among women is quite good about HPV and vaccination rates. But tell me, what is the reason we have still so small numbers of pap smears? The rate of pap smears, the rate of vaccinated is still unsatisfactory. What is your opinion about it? What should we do? Because we know that the main information source is doctors, gynecologists, internet.
Yeah.
What should we do to change it?
Maybe
To change this situation, very bad situation.
I think that government should play higher role in informing.
Government paid for vaccination since 23.
Yes, but to inform patients about, there are some, advertisements in television, but I think a lot of people still believe what they read in the internet, in some, websites that.
I know that it is a very difficult and very difficult question.
Yeah, and I think
I
that
couldn't
also
find-
some
Oh,
politicians they are expressing their not really medical opinions about
Okay,
this
thank you.
vaccination.
Thank you. Are there any more questions? So let me ask you, what was your contribution?
Okay, so I helped gather questions for our survey and also made presentation, and here I am now presenting this to you.
Very much again for really interesting presentation. And now I also have one information. When you go, like, please use this door, okay? Thank you. Okay, so our next presenter is already online. Could you upload your presentation via Zoom? Could you show us your screen? Can we hear each other, Agnieszka?
Yes, I hear you.
Okay.
Can you see the presentation now?
Yes, we can already see the presentation.
Okay.
Okay. But
Okay.
we can see material and method slide. Is it
Oh,
okay?
sorry. Okay.
Okay.
Sorry.
So our next presenter is Agnieszka Buchta with the work The Influence of Vitamin D Levels on the Development of Autoimmune Thyroids in Patients with Polycystic Ovary Syndrome. The floor is yours.
Thank you. So, good afternoon, ladies and gentlemen. My name is Agnieszka Buchta, and today I have the pleasure of presenting on behalf of myself and my colleagues the topic, the influence of vitamin D levels on the development of autoimmune thyroiditis in patients with PCOS. We will begin with the introduction, followed by the materials and methods, then results, conclusions, and finally discussion. I'm sorry for that. I don't know why this happened. Okay, a few words about PCOS. It is a complex syndrome characterized by reproductive and metabolic implications, which are listed in the figure below. And the diagnosis of PCOS is made based on the Rotterdam criteria. 2 of 3 points must be met, which corresponds to different phenotypes, as you can see in this picture, B, C, D, and when all 3, A. PCOS affects an estimated 8 to 13% of reproductive age women, and PCOS is a diagnosis of exclusion. So diseases that have similar clinical manifestation must be excluded. For example, hyperprolactinemia, Cushing's syndrome, hypothyroidism, congenital adrenal hyperplasia, or androgen-secreting tumors. The incidence of autoimmune thyroiditis in patients with PCOS is higher. And both PCOS and hypothyroidism are the most common endocrinological disorders among women of reproductive age. Why autoimmune thyroiditis and PCOS are linked? In the early stages of thyroid disease, inflammation may affect the ovaries, leading to increased production of anti-Mullerian hormone, which can predispose young women to develop PCOS. Anti-Mullerian hormone is a protein produced by granulosa cells in ovarian follicles during reproductive years and is a key marker for evaluating ovarian reserve. And low levels typically indicate reduced ovarian reserve, while elevated levels are often linked to PCOS. And now, we talk about early stages of autoimmune thyroiditis before. However, as the diseases progress and with advancing age, thyroid antibodies may begin to damage ovarian tissue as well the thyroid function, impacting both the ovarian reserve and reproductive health. Consequently, autoimmune thyroiditis may contribute to varying PCOS phenotypes influenced by the stage of disease and the patient's age. And autoimmune thyroiditis is associated with elevated anti-thyroid antibodies. To sum everything up I said before, but its hormonal consequences and impact on the ovaries differ with age. Moving on to vitamin D. It is a steroid hormone that plays a key role in calcium metabolism, bone health, and the prevention of various illnesses. It may be linked to development of several autoimmune diseases. Vitamin D deficiency has been found to be associated with increased risk to develop thyroid autoimmunity. And furthermore, lately a significant negative correlation was found between TSH and vitamin D levels. Moreover, the level of vitamin D deficiency is also closely linked to antibody levels and thyroid hormones. This means that vitamin D may directly affect how severe the autoimmune disease becomes. Vitamin D in PCOS patients. In those patients, it was shown that cholecalciferol supplementation improves the effects of infertility treatment. Vitamin D stimulates AMH production as well, which, as it was said, is highly correlated with the ovarian reserve preservation. And it improves folliculogenesis and reduces serum MAH levels in women with an excess of this hormone. Moving on to materials and methods, all patients were diagnosed with PCOS and 29 of them had autoimmune thyroiditis and 54 didn't. The patient's age and BMI were assembled. In the blood samples, the following parameters were also determined, such as TSH, free T4, vitamin D, total testosterone, and many more. And in this table, we can see those results. Moving on to the second table, then the patients were divided into individual phenotypes. And we can see a comparison of patients with PCOS and autoimmune thyroiditis and patients with autoimmune thyroiditis in their individual phenotypes. Results. Regarding into results, in table 1, vitamin D levels, as we have seen, were significantly lower in women with PCOS and autoimmune thyroiditis when compared to those with PCOS and without autoimmune thyroiditis. And there was no significant difference regarding other parameters and no correlation between phenotype of PCOS.
Halo, halo, Agnieszko, słyszymy się? Niestety nie mamy żadnego kontaktu z Agnieszką. Wydaje mi się, że wystąpiły jakieś problemy techniczne. Spróbujemy napisać na czacie. Jeżeli się nie pojawi, to po prostu przejdziemy do kolejnej prezentacji. Agnieszko, ze względu na problemy techniczne, czy mogłabyś wrócić do tego slajdu results i po prostu zaczniemy?
I'm really sorry for that.
Jakbyś udostępniła nam prezentację. O właśnie, to był ten slajd. Super.
Okay. So regarding into results, vitamin D levels, as we have seen, were significantly lower in women with PCOS and autoimmune thyroiditis when compared to those with PCOS and without autoimmune thyroiditis. And there was no other significant difference regarding other parameters, and no correlation between phenotypes of PCOS, TSH, and F3 T4 levels within those two groups of patients was found. And conclusions: vitamin D supplementation as a treatment can help prevent the development of autoimmune thyroiditis, and PCOS is directly connected to metabolic disorders. Therefore, it is important to pay attention to patients' vitamin D levels in order to prevent developing PCOS. And we suggest further studies in order to even better understand the mentioned topic. And thank you for your attention, and I'm deeply apologize for all the technical problems I had.
Thank you very much for your presentation. Are there any questions from the jury? So let me ask you, what was your contribution?
So my contribution to this work was to review the available literature and collect all the information and present it in relation to our work.
Okay, thank you very much.
I would like to ask, have you researched the correlation between PCOS with or without thyroid disease with the age of the patient?
No, we didn't do that. So as I said, I hope that we can manage to do further studies regarding this topic to even better understand mentioned topic, because I assume that it could be a correlation in this.
Okay, thank you.
Thank you.
Thank you very much for your presentation. And now let's move on to our next presenter for today, who is Zuzanna Socha, with the work Analysis of Risk Factors, Quality of Life, and Pelvic Organ Prolapse in Women After Total Laparoscopic Hysterectomy. The floor is yours.
Dear colleagues, esteemed judges, my name is Zuzanna Socha, and today I have the pleasure of presenting the work Analysis of Risk Factors, Quality of Life, and POPQ stage in women after TLH with vaginal cuff suspension to the sacrouretin ligaments, a single center study. Let me begin with a short introduction. Connective tissue within the lesser pelvis form ligaments whose role is to maintain the correct anatomical position of the uterus. weakening of the pelvic floor muscles leads to impaired support of those organs, resulting in their descent or prolapse. To describe the type of the damage, we can use the Delancey's clinical classification, which divides the pelvic floor into 3 levels and 3 compartments. To describe the severity of the defect, we can use the POPQ scale, in which the 0 stage indicates no prolapse and the stage 4 indicates a complete vaginal eversion. During the hysterectomy, the uterus is being entirely removed, but the ligaments supporting other pelvic organs are preserved to maintain their position. These pictures show the total laparoscopic hysterectomy. The intraoperative image show the moment when the monopolar hook, guided by the manipulator, delineates the incision line separating the uterus from the vagina. And now we can move on to the core of the matter. Our study included patients who underwent the TLH between 2021 and 2023 for indications such as abdominal uterine bleeding, uterine fibroids, and endometrial hyperplasia. The patients diagnosed preoperatively with the stage 3 or higher POP were excluded from the study. The quality of life was assessed using the Polish validated and standardized questionnaires 18 months post-operatively during the follow-up examination, and the response rate for our survey was 35.4%. Our patients' characteristics include the mean age of 53, mean BMI of 27, occupational type, and surgical indication for the surgery. In the follow-up examination, 21.3% of the patients were obese and 15% performed hard physical labor. The most common indication for the TLH were uterine fibroids, and our patients' results were compared to the literature. The risk factors for developing the stage 3 or higher POP after TLH included having had 2 or more vaginal deliveries, older age at last pregnancy and delivery, the history of abdominal surgeries such as abdominal hernia repair inguinal hernia repair, and the appendectomy, and also menopause. The outcomes of our studies were the incidence of developing the stage 3 or higher POP was 1.2%. These results were compared to the Finnish studies, where on the larger group of patients with a longer follow-up, the incidence was 1.6%. And I would like to draw your attention that these results are very similar. The Scandinavia studies using multivariate analysis of variance found that the other types of hysterectomy, that is other than TLH, had higher risk of subsequent visits and surgeries for prolapse. Quality of life was also assessed using the PQOL, POPDI-6, and PFIQ-7 questionnaires. The results from the PQOL questionnaire indicated that the patients had no, that the PQOL results revealed that there were no symptoms regarding various areas of life, such as sexual life, social life, travel, or work. And these results are shown on the graph. The POPDI-6 result indicated that the patients didn't have subjective symptoms such as feeling of the pelvic pressure, the feeling of the vaginal bulge, or the need for manual assistance with urination or defecation. And these results are also shown on the presented graph. The PFIQ-7 results indicated that there was no issues with urinary fecal incontinence, as well as pelvic organ prolapse during the daily activities. And the results are also shown on the graph. By superimposing our patient's result onto the cumulative survival curve without stage 3 or higher from the Scandinavian studies, we can predict that our patient's group will receive a similar outcomes that the patients from the Finnish study in the 10-year follow-up. And to sum up our results, the total laparoscopic hysterectomy with vaginal cuff suspension to the sacroiliac ligaments does not significantly increase the risk of the pelvic floor disorders. This procedure also does not negatively impact the patient's quality of life as measured by the PQOL, POPDI-6, and PFIQ-7 questionnaire. And the future plans include the extension of the study through a long-term follow-up of the current TLH patient database, the expansion of the patient's database, and the assessing quality of life in the multi-center studies. We have just established the collaboration with the Medical University in Warsaw and Lublin. Thank you very much for your attention. Here are our references, and I invite you to discussion.
Thank you very much for your interesting presentation. Are there any questions from the jury?
Surgery modalities we use it to hysterectomy. You tell us about the patients and indication to hysterectomy, total laparoscopic hysterectomy. But my question is, according to your knowledge, according to your results, and I am very glad you are going to perform in the future the same study with colleagues from Lublin, etc. It is important. Tell me which way, what modality of hysterectomy could be better against prolapse organ, pelvic organ prolapse, total laparoscopic hysterectomy or vaginal hysterectomy?
Well, having those two in comparison, the total laparoscopic hysterectomy would be better than the vaginal one, because during the vaginal one, we are kind of pulling the organs during the surgery.
During surgery?
Excuse me?
Pulling the organ during surgery through the vaginal hysterectomy?
Yes, for the vaginal hysterectomy, yes. We are during the procedure.
But in TLH, we don't pulling organs.
Yes, we are not pulling them down through the vagina, so that's why the outcomes should be better.
And
doing the dissection laparoscopy, so it's like the laparoscopic assisted vaginal hysterectomy, for example, is based on also the laparoscopic method, but the difference between the total laparoscopic and the laparoscopic assisted vaginal hysterectomy is that the moment of the cut, yes.
Yeah,
so
yeah, thank you very much. Okay.
Are there any more questions? So let me ask you, what was your contribution?
Yes, so I am very glad to say that we could contribute a lot in the study, starting from making the questionnaire, of course, under the supervision of doctors, through the contacting with patients for the follow-up, and we also took active part in the follow-up examination. We distributed the surveys, as well as we could learn how to examine the patients under the eye of our doctors. So we were very, very lucky to be able to do it.
Congratulations of your work. And now let's move on to our next presentation for today, which is the assessment of vitamin D levels in Silesian polycystic ovary syndrome patients, a retrospective study.
Good afternoon, ladies and gentlemen. My name is Weronika Curyło, and today I have the pleasure of presenting you our study about the assessment of vitamin D levels in the Silesian PCOS patients, a retrospective study. Thank you. Let's start with the basics. PCOS is short for polycystic ovary syndrome, and its prevalence is from 5 to even up to 20% of the women population, depending on the region. We use the so-called Rotterdam criteria to diagnose PCOS. These include ovulation and menstrual disorders, hyperandrogenism, biochemical and or clinical. Clinical being acne, hirsutism, alopecia, and a characteristic ultrasound image, which includes at least 12 follicles, 2 to 9 millimeters in diameter, or at least one ovary, which is enlarged at least 10 milliliters. And we can diagnose PCOS in adult women if there are 2 of the 3 criteria present. Using the criteria, we also differentiate 4 phenotypes of PCOS: PCOS A, PCOS B, PCOS C, and PCOS D. PCOS S is when we have all 3 of the criteria present. PCOS B is when we have ovulation and menstrual disorders, as well as hyperandrogenism. PCOS C is when we have hyperandrogenism and a characteristic ultrasound image. And PCOS D is when we have ovulation and menstrual disorders, as well as a characteristic ultrasound image. Now, we mostly associate vitamin D with its role in the phosphorus calcium metabolism, but there has been an ongoing discussion about its role in many endocrine pathways, such as regulation of the anti-Müllerian hormone levels, stimulation of the aromatase activity, as well as there has been much research on human cells that show that it has also an impact on protein in the endometrium, maybe having a correlation to infertility. Investigating the pathophysiology of vitamin D and PCOS, we decided to investigate this relationship between vitamin D and PCOS in the Silesian region. And for this, in order to do this, we analyzed medical records from 1,541 patients in the gynecological endocrinology unit, who were women aged from 18 to 49, hospitalized between December 2021 until June 2024, and there analyzed the medical records, paying special attention to serum vitamin D levels and PCOS phenotype, finally using Statistica 13.1 for statistical analysis. What were the inclusion criteria? As I mentioned before, aged from 18 to 49, clinically diagnosed PCOS, and residents in the Silesian voivodeship, as well as neighboring voivodeships. Did we exclude anyone from our study? Of course, and those were mostly women with endocrine diseases, all listed here above. So let's have a first look on our test sample. As you can see, the overwhelming majority were women from the Silesian voivodeship, 1,343. The majority of women were aged from 18 to 25, both in the whole study group as well as only looking at Silesia. In terms of vitamin D deficiency, the majority, unfortunately, had a vitamin D deficiency, fluctuating around 77%. It's actually no surprise to us, since actually right now there is a global pandemic of vitamin D deficiency, unfortunately. Oh, sorry, once again. So first, we wanted to assess if age affects vitamin D levels. And as we can see, in Silesia, other voivodeships, as well as in the whole study group, the p-value is lower than 0.05. Therefore, there is a correlation using the Pearson correlation coefficient test between vitamin D levels and age. And interestingly, there is a linear correlation. With age, the deficiency is slightly lower. So younger patients don't suffer from such a big deficiency. The older patients don't suffer as much of a deficiency as the younger patients. And we confirmed this by using two independent statistical tests. Next, we wanted to see and assess three independent factors, age and vitamin D in correlation to place of residence. And as we can see, both in Silesia and other voivodeships, the mean age and mean vitamin D level is quite similar. And using the Human-Whitney test, we associated that there is no association between age and vitamin D blood concentrations. Then we also wanted to see if there is a correlation between age and PCOS phenotype. The overwhelming majority of patients had PCOS-A. It was the most frequent PCOS phenotype. And although the diagrams may seem similar, mathematics doesn't lie, and there's actually only a correlation here in the Silesian voivodeship, being the p-value lower than 0.05. Also assessing the whole study group, the PCOS-A is also the most frequent one, and actually it appeared more frequently in younger women. So continuing the thought of mean age and PCOS phenotype, we can see that the mean age of PCOS-A is 24.9 years and PCOS-D 25.8 years. So PCOS-A is the youngest one and PCOS-D is the oldest one. So there is an association between age and PCOS phenotype. And also, we already know the mean age, but we also wanted to know if there is a mean level of vitamin D. And PCOS-A was the lowest one, 23.3, and PCOS-D was the biggest one, 24.7. But the difference, 1.3, isn't that big, and there was actually no association between PCOS phenotype and mean vitamin D level in blood serum. As a summary of the whole lecture, I created a take-home message just for you to get the essential data for you to remember. So the vast majority of female patients tested are vitamin D deficient. Secondly, vitamin D serum concentrations increase with age. The place of residence in Poland does not affect serum vitamin D concentrations, and vitamin D concentrations have no impact on developing a specific phenotype of PCOS. Thank you very much for your attention. Feel free to ask any questions. I will gladly answer them. Thank you.
Thank you very much for your presentation. Are there any questions from the jury?
Yes, you find a positive correlation between the age and the level of vitamin D. And I would like to ask, how can you explain it? Why younger woman has got lower level of vitamin D in the serum? Why?
Thank you. So I have an opinion on this, that maybe older women, slightly elder women, already have the diagnosis for a longer period of time and have a better education about their disease and better health education in general. So they may already supplement vitamin D orally. We didn't.
The correlation, it was directly straight.
Yes. So the deficiency was lower in older patients than in younger patients. Yeah, and that would be my idea why it happened that way. But it would need some further investigation, and I think that's a good idea for further research.
Okay, thank you.
Thank you.
Know everything, almost everything about women, but about men. As a man, I should change my place of life in another region of Poland.
No, of course not.
Thank you very much.
Thank you. Would you like to add something? Thank you. Thank you very much.
Very much. And what was your contribution, Veronica?
Yes, all right. So my contribution to this work was analyzing the medical data. I gathered also the medical data from hospital data. Then I also created the presentation, of course, and I'm presenting it today. And also I gathered some of the articles that we studied for the upcoming article about this research.
Thank you very much and congratulations on your work. And now I'm really happy to welcome our next presenter from Romania. Elena.
Hello.
Ariana, are you with us? I'm really happy.
Yes, can you hear me?
Yes, we can hear perfectly. Okay, so our next presenter with the work Where Life Falters, a study of spontaneous abortion and the shadows it casts.
I'm gonna share my screen right now. Can you see it now?
Yes, we can see it perfectly. Okay, you can start.
Hello, everyone. My name is Ariana Bulboacă, and I'm going to present you a study about the spontaneous abortion and the shadow that it casts. Spontaneous abortion, it is defined as the loss of a non-viable embryo or a fetus before 20 or 24 weeks of gestation. It is a common complication with multifactorial causes, including the maternal age, prenatal care, and various medical or lifestyle-related factors. It is estimated that approximately 1 in 5 women will experience a spontaneous abortion during their reproductive lifestyle. According to the articles in The Lancet, it is estimated that around 23 million spontaneous abortions occur globally each year, representing 44 pregnancy losses every minute. For the methods and the results, we studied 100 patients that were admitted between January 1st and December 31, 2022 in our obstetrics department hospital in Iași. We included the ongoing incomplete missed abortions and the cases that required the medical abortion induction or the uterine evacuation for maternal or fetal indication. The study was conducted in accordance with the Declaration of Helsinki, and the participations were asked for consent in an electronically way. Why we chose, why it matters. We chose this for its relevance and the personal and medical significance. We also know that the spontaneous abortion is a common but under research. There are no global definitions, there are limited data on the complications, and it is underreporting. And we also know that the outcomes is impacted by the socioeconomic and regional factors. We want to better understand we want to better understand the spontaneous abortion in order to help to improve the care, the prevention, and the emotional support. The study aim was that we wanted to characterize patients admitted with miscarriage or pregnancy termination in the northeastern Romania. We wanted to assess the incidence and evaluate the psychological effect, because literature often treats pregnancy loss as a single experience, overlooking the distinctions between miscarriage and a termination for fetal anomalies. As you can see here, we have characterized our patients through groups. We have the age distribution and the local distribution where the patients live. For the results, it indicated that the incidence of spontaneous abortion is equally distributed, 23% between 26 and 30 years old and 36 and 40 years age groups. The lowest incidence was observed in patients over 41 years old, accounting for only 6 of our cases. So, surprisingly, and contrary to our expectation, the lowest incidence of abortion in our study was observed over 41 years age. Existing literature consistently shows that the risk of spontaneous abortion increases with the maternal age. primary to the declining oocyte quality and reduced endometrial receptivity, especially after the age of 40. We also wanted to distribute our patients to see how many pregnancies they had in their medical history. So out of 86 hospitalized patients who were multiparous, 26 were in their second pregnancy, and only one patient was in her 10th pregnancy. So what are the factors that may affect the spontaneous abortion? We have the pregnancy history, the lifestyle, the genetic factors, immunological factors, and of course the maternal age. And we only studied a part of them. For the medical history of the patients, we tried to highlight the most common pre-existing conditions. And the most frequent comorbidity that was presented in 9% of our cases was thrombophilia. And the other conditions reported were also imported, like cervical insufficiency, uterine prolapse, and ovarian cysts. We wanted to study the psychological side of the story. So, what was the impact? We saw the emotional effect that included grief, guilt, anxiety. We also showed that there is an impact on the partners. So the men are also affected through this process, but it is less visible. And we also wanted to show that the importance of support need, the empathic care, the psychological support, and open dialogue are the key for healing. So we did, we wanted to test our patient, and we realized that 94% of our patients showed sadness, 93 showed mood swings and crying, and 62 of them showed guilt. And also, only 50% of our patients ended up with depression. So what are the conclusions? Higher incidence of pregnancy loss occurs in women under 35, correlating with peak reproductive age. Women from rural areas show an increased risk of spontaneous abortion. Patients with thrombophilia have a significantly elevated risk and require close monitoring, and psychological and emotional support remains insufficiently addressed in clinical care. So my take-home message is a woman who endures the loss of a pregnancy carries not only the weight of grief, but the strength of a warrior, quietly fighting battles no one sees, yet rising with resilience each day. And please don't forget that abortion is a woman's right. Thank you very much.
Thank you very much for amazing presentation. Are there any questions from the jury?
Thank you very much. Excellent work. I have the question about how was the questionnaire distributed? What was, of course, your contribution? And the second question is when you, in your questionnaire, asked about this emotional status of the patient, did you use some validated questionnaire, validated methods, or do you plan to expand this research by using such way of measurement? Thank you.
Thank you very much for a question. First of all, we chose a year, and we contacted each patient that was admitted to our hospital in that year. So we contact them through phone, first of all, to ask for consent, and then ask them to come back to the hospital so we can talk and make the study. My contribution to this study, in Romania, I'm in my final year, I'm in my 6th year. We have a subject called public health and management. So we had it as a project to study, to choose a subject and make a study out of it with a professor of our choice. So this is why I chose gynecology, because this is what I want to do in the future. And all the work I did it with my teacher. About the psychological question, in order to find our results, we asked them to come back and we talked with the patient near a psychiatrist that asked the right questions in order to have the most concrete answer from our patient.
Are there any more questions? So, Ariana, thank you very much for your presentation.
Thank you very much.
We are really happy that you decided to take a part in our Silesian International Medical Congress. And yeah, we wish you all the best for your future and see you maybe one day. Thank you.
Thank you very much. Bye.
Bye. So now let's move on to our next presenter, which is Alexandra Leziak, with the work Double Responsibility, Eating Disorders During Pregnancy.
Dear jury, dear colleagues, my name is Alexandra Leziak, and today I'm honored to present our work on maternal mental health. Before we go into details, I would like to briefly walk you through the structure of today's presentation. We will start with introduction, next going to the aim, materials and methods, results, conclusion, and discussion final. Let's begin with the context of our study. Pregnancy is a time of intense physical and psychological change. Eating disorders may worsen this time. I mean purging, restriction, or binge eating. Eating disorders can negatively impact on maternal health or fetal development. Bulimia may tends to decrease, while anorexia or binge eating disorder tends to decrease during pregnancy. Many cases go unreported, unfortunately, so the problem is likely underestimated. Interestingly, some studies show pregnancy as a high-risk period in the context of eating disorders, while others show symptoms remission this time. Current epidemiological data estimates that prevalence of eating disorder in general women population as 4%, while during pregnancy this increased to 5 to 7%. There are many risks associated with eating disorders, so it poses risks as miscarriage, a low birth weight, increased morbidity, mortality, or preeclampsia. The aim of our study was to analyze the relationship between eating disorders symptoms, depression, and perceived social support, and also to identify the factors associated with eating disorders. We conducted our research on a group of over 180 pregnant women with a mean age of 30. We used 3 validated questionnaires to assess eating disorders, severity of depressive symptoms, and perceived social support. On the right, you can see a QR code, which was used by us to collect answers from our responders. Here we can see some details about study group. And most of our responders were from villages and smaller cities. Let's take a look at some general findings. Let me start with eating disorder examination questionnaire. 6% women met the eating disorder examination criteria, while 5% had binge eating disorder incidents during pregnancy, while only one woman had one woman fit the criteria of developing binge eating disorder during pregnancy. As the first time in their lives. Secondly, 42% of our responders showed symptoms of depression ranging from mild to severe. And the positive result is that the majority of our responders perceived high social support. Let's take a look at some correlations with eating disorders. Higher scores in eating disorder examination questionnaire was associated with lower perceived social support and also with higher depression scores. What about risk factors associated with eating disorder? Higher body mass was associated with more severe eating disorder symptoms, especially in the context of appearance and body weight control. To conclude, women are especially at risk of developing eating disorder, especially during pregnancy, which is a particularly vulnerable period of life. And many women experience depressive symptoms and poor social support, which is strongly correlated with higher scores on eating disorder examination questionnaires. There is a pressing need for a holistic approach to mental health during pregnancy. So summing up, we have to improve dietary education and implement routine screening for eating disorder in prenatal care. And finally, we have to remember that early intervention and prevention leads to better outcomes for both mother and child. Here's my bibliography, and thank you so much for your attention, and I'd like to invite you to the discussion.
Thank you very much for your presentation. Are there any questions from the jury?
Thank you very much. It was a very interesting study. Binge eating syndrome is, for me, it's quite new and very interesting because I well know metabolic programming. It is hypothesis, but very interesting, and I would like to ask about it because stated that different environmental factors influence in the different part of life during pregnancy, for instance, during first month of life, and change metabolic program of our whole metabolism, what was very important for future life, and create in distinct time quite different, very dangerous disease. And can you see that this problem, your measure, will connect with this hypothesis? And it is the first question. The next question is bulimia and this problem in pregnancy. It is the same or quite different?
In the context, is the same bulimia and binge eating. So I will start with the second question. No, bulimia and binge eating disorder is other disease because bulimia is in the most cases is associated with some
vomitus. Vomitus?
Yeah, or other compensation. For example, no food on the next day or extreme physical exercises. It's two options of burn extra calories, but binge eating is mostly associated with emotions, with stress. So I mean that during especially pregnancy and maybe first months or weeks after childbirth is associated with stress, with new role in the life of a woman, and hormones, of course.
It means that bulimia is not a risk factor for this syndrome. No, not at all.
I think that's not, but I think we should check in meta-analysis because I think that studies may not be the same.
What about this hypothesis I said?
About hypothesis, about stress.
Yeah.
Yeah, I think it's a huge factor. And I think that if we would ask our friends or women on department, I think it will be true.
But if we found this disease during pregnancy, we can say then in the future, in the fetus and the oldest will be not correct in metabolism disease? More frequently will be?
Nextly, we will have problems with metabolism.
Yeah.
Yeah, I think yes, because binge eating is not physiological for us, for our body.
Thank you very much.
Thank you.
Excellent.
Thank you very much. And what was your contribution?
My contribution was to get answers by a QR code with my colleague, and also to present here and to prepare presentation.
Thank you very much, and congratulations on your work. And now let's move on to our last presentation for today, BME and insulin resistance in women with polycystic ovary syndrome, a cross-sectional analysis.
Dzień dobry Państwu, Szanowna Komisjo. Jako na zakończenie tego owocnego dnia chciałabym przedstawić prezentację odnośnie naszej pracy, tym razem po polsku. Nasza praca dotyczy zależności pomiędzy BMI a insulinoopornością u kobiet z PCOS. Więc tak, zacznijmy od podstaw. Zespół policystycznych jajników to jest bardzo powszechne zaburzenie w grupie pacjentek w wieku rozrodczym i wiąże się często z różnymi metabolicznymi zaburzeniami, takimi jak otyłość czy insulinooporność. BMI i wskaźnik insulinooporności HOMA-IR to kluczowe markery zaburzeń metabolicznych. Celem tego badania była ocena zależności pomiędzy BMI a wskaźnikiem insulinooporności oraz zależności pomiędzy procentową zawartością tkanki tłuszczowej, tłuszczem trzewnym, a różnymi biochemicznymi markerami zaburzeń metabolicznych u pacjentek z zespołem policystycznych jajników w porównaniu z grupą kontrolną, którą były pacjentki bez zespołu policystycznych jajników. Analizie poddane zostały 212 kobiet. 167 z nich miało zaburzenia związane z zespołem policystycznych jajników i te pacjentki podzieliłyśmy na 4 fenotypy, a 45 pacjentek stanowiło grupę kontrolną, która nie miała stwierdzonego zespołu policystycznych jajników. Badałyśmy antropometryczne parametry takie jak BMI, wskaźnik talia biodra, procentową zawartość tłuszczu i obszar tłuszczu trzewnego oraz biochemiczne parametry takie jak glukoza i insulina, z której wyliczyłyśmy wskaźnik HOMA-IR, SHBG, lipidogram, testosteron oraz też inne parametry, które nie wykazały istotności statystycznej. Do naszej analizy użyłyśmy korelacji Pearsona i istotności statystycznej P. Nasze wyniki potwierdziły dobrze znaną korelację pomiędzy BMI a insulinoopornością, co wyszło nam po prostu, że im wyższe BMI, tym większa insulinooporność. Zauważyłyśmy również bardzo silną korelację pomiędzy procentową zawartością tkanki tłuszczowej a tkanką tłuszczową trzewną. Tutaj ten współczynnik R wynosił około 0,95, co jest wynikiem bardzo wysokim. I zarówno procentowa zawartość tkanki tłuszczowej, jak i obszar tłuszczu trzewnego wykazały istotne związki z insulinoopornością, co zatem idzie ze wskaźnikiem insulinooporności, i różnice między grupą kontrolną a grupą badaną też wyszły dość znaczące, co właśnie podkreśla to, że zespół policystycznych jajników tutaj sprzyja tym zaburzeniom metabolicznym. Wyniki naszego badania sugerują, że otyłość brzuszna mierzona przez obszar tkanki tłuszczowej trzewnej koreluje z zaburzeniami metabolicznymi w zespole policystycznych jajników, odgrywa taką kluczową rolę w tych zaburzeniach. Pomiary tej procentowej zawartości tkanki tłuszczowej i obszaru tkanki tłuszczowej trzewnej dostarczyły nam takich informacji, które uważamy, że wykraczają poza poziom BMI, co może tutaj być cenną wskazówką na przyszłość, że pacjentki powinny być właśnie diagnozowane na podstawie, w sensie pacjentki z diagnozą powinny mieć też mierzony poziom tej tkanki tłuszczowej trzewnej, a nie samego BMI, ponieważ pacjentki z prawidłowym BMI mogą już zmierzać w stronę tego, że właśnie ta tkanka tłuszczowa trzewna rośnie. Wyniki dotyczące trójglicerydów też nam pokazały, że insulinooporność u tych pacjentek wiąże się nie tylko z otyłością, ale też z zaburzeniami lipidowymi, co zwiększa ich ryzyko sercowo-naczyniowe. Ograniczeniem naszego badania jest jego przekrojowy charakter, który niestety nie pozwala na ustalenie kierunku zależności przyczynowo-skutkowych. Dodatkowo stosowałyśmy w celu oznaczenia tych antropometrycznych właściwości bioimpedancję, która też ma swoje ograniczenia. Jest to na przykład stan nawodnienia pacjentki, zjedzony posiłek, a nawet zwykła zmienność pomiędzy urządzeniami. Jeśli chodzi o dalsze możliwości rozwoju badania, to chciałybyśmy zanalizować różnice pomiędzy fenotypami w zespole policystycznych jajników oraz może w przyszłości zaobserwować, jak zmienia się ten poziom całkowitej tkanki tłuszczowej i tkanki tłuszczowej trzewnej po redukcji masy ciała oraz po zastosowaniu farmakoterapii. Podsumowując, nasze badanie wykazało wyraźny związek pomiędzy BMI a insulinoopornością u pacjentek z zespołem policystycznych jajników. Bardzo silna korelacja pomiędzy procentową zawartością tkanki tłuszczowej a tłuszczem trzewnym podkreśla wagę dokładnej analizy składu ciała w tej grupie pacjentek. I włączenie pomiarów takich jak procentowa zawartość tkanki tłuszczowej i tłuszcz trzewny może pomóc tutaj pozwolić na lepszą terapię tych pacjentek. Dziękuję bardzo.
Thank you very much for your presentation. Are there any questions from the jury? In English.
Thank you for your presentation. It was really interesting, especially for me, because we all know that there is the debate going on that BMI is not perfect, it's not sufficient. So and as you showed, this is true. So you have the contribution to this analysis of other methods. So I would like to hear from you, what are your recommendations for future clinical implications of this study? So what can be measured? Yes, in addition to BMI? That would be the first question. And the second question, because you analyzed also and you searched for the correlations, for the statistical significance between also other factors. I saw that there was WHR and SHBG. And you mentioned, so I would like you to just said, so there was no statistical significance. Yes, you mean between this? Thank
It
you.
was statistical significance, but it's not difference between the control group and the study. Yes, study group. So this is the answer to the second question, and the first question.
The clinical implications of your study, so BMI, and what's more to evaluate?
Think that WHR is a good and very simple method to measure, but bioimpedance and percent or body fat and VFA is a way better method to sorry to
make the additional information. Yes.
Yes.
Thank you.
Thank you very much, and I'm sorry.
And you said a lot about the correlation between BMI and insulin resistance in women with polycystic ovarian syndrome. But have you got any knowledge about the correlation between the insulin resistance and BMI with women without polycystic ovarian syndrome? Is the same or is different?
Yes. It's also there is a correlation, but much lower than in women in PCOS.
Okay, thank you.
Thank you very much.
Thank you very much. And what was your contribution? The last question.
So me and my colleagues do all statistical analysis. I did presentation and present for you today.
Thank you very much, and congratulations on your work. So all the submitted papers have been presented for today. We congratulate all the presenting authors for your work. And at this point, I'd like to ask the jury for a few words to sum up our session. Maybe Professor Anita Olejek.
Thank you very much. It was really a very interesting session and very interesting papers presented by our speakers. And I must admit that I see a big potential in these people, and all of these papers are very interesting, and most of them will be the start and the beginning of their future scientific work. And I assess their presentation very highly. Also, their language and the way they speak was really impressive. So it is very good for the future of our university to have such a good speaker.
Thank you very
Thank
much.
you very much.
Maybe also someone who is present would like to say something, also in Polish.
Speaker, it was a fruitful time for us, all us, and as said Pani Professor, I agree with her in her all speech.
Thank you very much. So at the end, we would like to cordially invite you for the decoration and closing ceremony of the SIMC 2025 conference, which will be held in A3 Hall on the 9th of May at 5 p.m., which is today. You are also welcome to join us for the after SIMC party at DSO at 9 p.m. And more information can be found on Facebook, even Carlos from SIMC 2025. On the behalf of the Student Scientific Society, I'd like to thank you all for the participation at this session. Thank you very much. And once again, congratulations.
Thank you very much.
Thank you very much, Professor.
Congratulations. Thank you very much.
Thank you very much.
And also thank you for the organizers. Yeah, it was very, very good organized.
Thank you, and I'm sorry for some technical problems. To jeszcze raz bardzo dziękujemy komisji za przybycie. Zbiorę teraz karty. Tak, jak najbardziej.
A co z moją kartą? Czy ją